with MASTERCLASS, a pivotal topic exploring the intricacies of hand surgery. This session sets the tone for a comprehensive exploration. It's our distinct pleasure to invite our respected chairperson, Dr. Anil K. Bhatt and Dr. Ravi Gupta, to graciously take the stage. Your expertise and guidance will illuminate our discussion. We humbly request your presence to lead the proceedings. Thank you.
Good morning. So, without wasting any time, I invite Dr. Bain to start the masterclass.
Thank you very much. It's a great pleasure to be here, and this is one of my favourite topics. It's the whole concept of how distal radius fractures occur and how to assess them and hopefully put them back together. These are my conflicts of interest, which may be relevant for this presentation. So we can see here in this cadaveric model, we have a volar approach to a fracture of the distal radius, and as we elevate the distal fragment, we can see the metaphyseal components. They all remain attached to their associated ligaments. And we can see here that we've got the capitate and all the associated adjacent ligaments and bone fragments surrounding that capitate. So all those ligaments remain intact and the articular fragments remain attached to the appropriate ligaments. This is some work on the microstructure of the distal radius that we did some years ago. So we can see the subchondral bone plate distally and these arches that go down to the metaphysis, and there's very fine and thin intermediary trabecula that span in the metaphyseal area of the bone. The radius is clearly important for loading across from the articulation. The other aspect, looking at the micro CT, we can see on the left wonderful dissections by Amit Gupta, who's here at this meeting, but we can see that we've got the interosseous membrane and the space Shenton's line between the radius and the ulna, but there's a calcar which is positioned on the distal aspect of the radius here, which goes across from the shaft and then it loads to the ulna. And so the point that Shekhar makes is that when we're loading through the ulna, through the radius, that we can have increased impaction at that area. The other point that's interesting is that the calcar is thickened both in the anterior and posterior planes, and we can see on the image on the right how we've got the subchondral bone plate with the fibres, with the trabeculae passing down to the volar aspect of the shaft of the radius. This is the critical corner. The critical corner is important for taking the load from the distal radio-ulnar joint and from the lunate facet, but also providing stability to the distal radio-ulnar joint and the radiocarpal complex. Looking at these images here, we can see the dorsal cortex is very thin, and we can see how it characteristically buckles and becomes comminuted on the dorsal aspect, whereas on the volar aspect it tends to be a clear break without buckling. It's a different type of bone structure. The watershed line, which should be renamed the watershed ridge, the reason it should be called a ridge is because it's a ridge and it's not an imaginary line. It's important for its attachment to the volar carpal ligaments, and the volar carpal ligaments attach distal to it. The concept of why it was called a watershed line is related to the geography. If rain's coming down, you have the watershed zone, and the fluid will, the rivers will drain to the sea on that side, and on the other side they will drain away, depending upon that watershed ridge. The watershed ridge is the most volar aspect of the distal radius. These are my patients. I think in your hospitals they're similar, although I think you have more motorbikes and people falling off bikes, ordinary bikes as well. We can see here this fracture template which we created on 100 patients. We can see the associations where the fractures occur, and we identified a number of vulnerable areas, and we defined that the vulnerable areas for fractures did not tend to be where the ligaments are. So at first we thought the ligaments were protective, but I actually think that's not the case. I think the ligaments are associated with the initiation of the fracture. So the ligaments are important for the association of fractures. We looked at also a series of two-part fractures. We found a similar orientation of the fractures, and again the fractures occurred between the ligaments. An interesting observation was that if it was a low energy injury, every single patient followed this basic rule. However, if the patient had a very high energy injury, then the fracture would be more defined by the forces that go through the radius. So the magnitude of the force is important, the ligaments are critical, but also the type of fractures that we see in our practice and your practice I expect are reproducible. We see the same characteristic types of fractures, and this is important because it enables us to get our head around some of these concepts. We developed a two-part classification which is quite simple. Basically there are these primary fragments which includes the radial styloid, dorsal ulnar and volar ulnar cornels. And these are the critical points of the associated fractures that we see in clinical practice. The ones on the bottom are probably a little bit less common and almost become a configuration of one part and another. So we call these secondary fragments. So if the patient falls down on the outstretched hand and the wrist goes into forced extension, there's a lot of tension that goes through the volar carpal ligaments, and this causes a compression of the articular surface from the lunate as it hits into the distal radius. It initiates the fracture at the subchondral bone plate, and there's a propagation of the fracture leading to the displacement of the fracture. So this is what we would refer to as the osteoligamentous unit. So you can see the metaphyseal bone, the ligament, and then the lunate. So those three components still remain together despite the fact there may have been a fracture, and that's what we saw in the cadaveric specimens. So this is an important finding because you can rely on that once you identify the fractures to be able to work out how to treat your patients. So the mechanism of injury, so if we have the wrist going into ulnar deviation, we can see the force going through the hand, lunate and the lunate facet, and we can get this punching lesion of the lunate facet. But those ligaments on the short radiolunate ligament, as in this example, remain intact. A die punch fracture is a little bit different where we can see that whole fracture fragment goes down. The point I want to make is how the impaction of the bone is like a centimetre proximal to the actual articular surface, and we have that die punch fracture as seen there. And another example where the first one was from the lunate facet, this one's from the scaphoid facet. So we have that impacted bone and we have the die punch fracture going down, and of course we have to elevate that like we learnt with tibial plateaus. So the primary osteoligamentous units, as we can see here, so you can see that the lunate facet, short radiolunate ligament and the lunate, and the fracture fragments. So if the patient has a fracture, they will displace, and once we put it back together, so the orientation of those fracture fragments remains intact. So this concept has been noticed by some other groups, including the AO Foundation and the team from Medartis or IBRA. And we can see that the fantastic artwork on the right, and you can see my pretty ordinary artwork on the left. But you can see how they've been able to use the concepts that we developed some years ago to help understand exactly how the fracture fragments work. But more importantly, I think that our friends from Austria, you can see that Australians and Austria are very similar, although we're a little bit different. I think our wine's better. But what we can see here is that what they've been able to develop is a whole series of the different fracture configurations, but define the sort of plates that we should put onto the fracture fragments to ensure that we can get a good stabilisation. I think this is an important concept. So going on to the osteoligamentous units, we were all taught to use ligament ataxis and apply traction, and what we see with that is you can see the radial styloid has not just gone up, it's actually tilted because of the orientation of the ligaments. And in fact, with ligament ataxis, the distal radius articular surface does not reduce. It realigns the limb, but it does not realign the articular surface. So if we have this sort of configuration, we've seen Dr. Gupta's beautiful images again, and we can see the associated fracture. So you can see the Shenton's line is broken, and you can see that the distal radioulnar joint's unstable, and the tip of the ulnar styloid has a fracture as well. So the shaft of the radius is translating towards the ulnar. Just a Gagliard's equivalent type injury. We found the use of a laminar spreader to be particularly useful in these cases prior to that, I found I really couldn't reduce these fractures properly. So he placed a laminar spreader between the radius and the ulnar, and that opens the space up. And as a consequence of tightening up the interosseous membrane and the distal radial-ulnar joint ligaments and the ulnar carpal ligaments, it actually translates the whole carpus around, rotates it in its correct orientation and alignment. It's like magic in a way, but it's such an important principle, and it's something that we commonly use in our practice to be able to ensure that we get a better reduction. So you can see on the image on the left, by using the laminar spreader, we're able to get the alignment and maintained in the correct position. I'd like to acknowledge Mark Ross, who's done some very interesting work, and you should read his papers on this, where he talks about the translation and how that affects the importance of the stability of the distal radial-ulnar joint. And so what his experience is that since he started using similar techniques, he found that the distal radial-ulnar joint instability problems actually went away. The other point that he makes actually is a radial column plate will tend to align the radial border of the radius and correct the deformity. So it actually does something similar to what we see with the laminar spreader. So this is a case of mine from some years ago. We've opened it up, the volar approach, similar to what you would use. I've placed traction on it, so you can see it's opened the fracture up. We've put a laminar spreader in there, and then with flexion. So we've found with this combination that we're able to reduce the articular surface and the distal radius fractures in the majority of cases. I refer to this as the multi-directional ligament ataxis. So it's not just straight ligament ataxis, it's creating all the planes there so that each individual ligament is orientated to reduce the distal radius. In Flinders Medical Centre, which is where I work, our trauma unit tend to manage most of the fractures, and we review the patients who had volar marginal rim fractures, and we were quite surprised at the high incidence of associated instabilities, including volar instability, scapular instability, distal radial-ulnar joint instability, and ulnar translocation. We also found a number of these cases had failure of fixation, and some patients required revision surgery. And if we look at this image on the bottom left, we can see that this would be what we'd call a failure to capture. So this fragment has gone over the top of the plate, and this is failure to contain. So the plate should have been a little bit more ulnar so that it grabs this volar ulnar corner. So these fundamentals of surgery are critical in this type of clinical problem. And I expect that you see that in your practice every month or so. You'll see these sort of complications, and I think it's something we need to really focus on to minimise the chance of that. So what's going on with this? We've got a volar rim fracture seen here, at least the volar instability with the lunate subluxation, scapular instability, and there can be tears of the associated distal radial-ulnar joint capsule and the associated ligaments. And the other thing that can happen is if this ligament complex extends over to the radial side, you can now get ulnar translocation. So this may seem as an extreme example, but it's actually not that uncommon. So this is a clinical case that presented to us some time ago. We can see that we have this volar facet fracture, and we can see how that the scaphoid is not contained in position, and we can also see how the lunate is sitting with that fracture fragment as well, so that we've lost stability of the whole carpus. But the point how the scaphoid is not contained is an important one. And so if we look at some of the ways to assess this, including stress fluoroscopy, we're able to identify that the carpus can be completely unstable. We can look at with arthroscopy, such as this example here. The radial styloid is on your right. This is the associated fracture that we're looking at. And as this is elevated, we can see the articular fragment has the ligaments attached, and then the whole volar ligament complex is avulsed from the lunate facet. So we call these sleeper lesions, the ones that are sort of fine and a bit difficult to see, and it can be associated with this subluxation, what I call a rim crescent fracture, and there may be some small areas of dust on the volar aspect. And these cases are typically occur where there's a lesion to the stabilising structures. The wrist is still held together by the secondary restraints, but it's unmasked with mobilisation and time. You get a better image of that rim crescent lesion at the top. So these cases are high-risk injuries with a high energy, associated dislocations and a lot of swelling. The diagnosis can be made with MRI scan if you're not sure. In my practice, I only occasionally do that. I often do stress radiographs or fluoroscopy, and I often add arthroscopy to manage some of these complex injuries. The volar rim fractures are very complex areas. There's many different ways to manage them, but I think the principle is here. So if you've got this fracture, the very first fracture we can see in this position, a standard plate will work very nicely. We put the plate up to the watershed ridge. However, it's more distal. We need to capture that bit of bone and the associated ligaments and bring it down with some form of hook or capture mechanism. In these cases, the plate's more distal, so the plate will need to be removed, often at a period of, say, 3 months. There are some patients where it's more distal, where a containment plate that wraps around the whole distal radius may need to be used, or even extreme cases, a bridging plate. We've also found in the revision cases the volar ulnar approach can be an important addition. I will stop there, Mr. Chairman, that way I'll be on time. Thank you. So in summary, the concept of the osteoligamentous fractures allows us to define the type of fractures and understand the type of ligament injuries that occur. Thank you very much.
Thank you, Dr. Bain, for that interesting topic. We can take 2 questions from the audience. Anybody wants to touch the black box? Yeah, please.
Thank you for a fantastic lecture. Just one question. Everyone is talking about critical corner, about short radial lunate, and so a little bit forgetting about styloid of radius cuff capitate. What is your thoughts?
Good question. So the patients who have more of an ulnar-sided injury will have the short radiolunate ligament and the volar lip of the distal radius. Those patients who have an associated fracture, including the radial styloid, can have an avulsion of the radioscaphocapitate ligament. So the things that we've seen that can be easily missed, I think, is the ulnar translocation, and particularly the volar translocations if the fracture is very distal. I think we need to ensure that these complex cases are managed by people who have experience in them, and certainly not leaving junior doctors to manage them. So I think they're the most important points. And finally, there are some patients who also have complex carpal injuries associated with the distal radius fractures, which may not be appreciated just on plain radiographs.
Thank you so much for that paper. It just seems a bit contradictory, because you said that if you apply longitudinal traction, the articular surface just doesn't fall back in place at all. And that's the principle of ligamento-taxis which all the external fixators are using. Statistically and all the literature-wise, it's been shown that the volar plate or whichever plate we're using is not superior to an external fixator in the management of distal radius fractures. So does that seem contradictory to you? Because if we say that an external fixator will not align the fractures in place, which means the external fixator should be not used. Yeah. But we find that it is used and it's not being shown to be inferior, or maybe the plate is not superior to the external fixator.
I think you, in your practice, should probably put them all into splints. I think the principle of trying to reduce the fractures is a good one. I think we should fundamentally do that, but you're right that there are limitations in the results, particularly using just a distractor. There are limitations if the results are not as bad as what you would think with regard to having displaced articular surfaces. But I think that's partly related to the fact that we don't have good assessment tools. I think if we were able to advance our assessment tools of how people ergonomically work the wrist, how they transfer load, and how that they use all the proprioceptive factors of the wrist, I think we would find that the better anatomic reductions would be better. We've recently done some work where we've looked at the centre of rotation, particularly of the capitate. So all the models of looking at the primary angles of the distal radius actually don't show a lot of change depending upon the outcome of the patient, which is actually your point. But if you look at the capitate centre of rotation, which is the centre of the wrist, we've found that the orientation of the centre of rotation is critical or more important with regard to providing a normal functioning wrist.
Thank you, Dr. Bain. I now call upon Dr. Chaitanya Mudgal for his talk. The science and bias of slack and snack.
All right. So, most human beings, by design, we have likes, we have dislikes, and we learn from our past behaviors. That is called heuristic learning. Most of us in our profession also learn from science, and as you saw me talk yesterday about evidence. So what you're going to see over the next 15 minutes is what I've learned over the last 30+ years and how I built up my own biases from heuristic learning. So why does a snack or slack develop? We know that the arc of curvature or the rotation of the radius and the scaphoid are different. So naturally, when there's uncoupling of the scaphoid and the lunate, the two curved surfaces don't match, and there's dorsal translation of the scaphoid, leading to edge loading, as shown here with these two spoons on the right-hand side picture, and causing a progressive, predictable, and irreversible change in the articular cartilage, which happens over a period of time, as we'll see. How long does it take? Well, cystic changes almost certainly within 10 years for a snack wrist. And then either a snack or a slack, you can get predictable degenerative changes within 20 years, and almost certainly pancarpal arthrosis within 30 years. Now, this is old data, but I think it still has withstood the test of time. I don't need to belabor this point, but the stages of the snack as depicted here with the distal scaphoid, then the scaphocapitate, and finally pancarpal. Whereas in the slack, it's a little different. It's distal scaphoid, proximal scaphoid, and then capital lunate. So these are the predictable stages of snack and slack development. But does that happen every time? And that's the question you got to ask yourself. So if you saw that the subtitle of my talk was Answers to Commonly Asked Questions, and this is something that was asked to me many years ago, that is there a scaphoid non-union pattern which will not develop this? And that got me thinking, and I realized Nakamura had already answered this many years ago, because he identified the distinction between the B1 and B2 fractures. And the theory was that in B1 fractures, the fracture line is proximal to the scapholunate intraosseous ligament attachment, and therefore the chances of developing a humpback are much, much less. Whereas those fractures which occur predictably distal to the attachment of the scapholunate ligament inevitably lead to the formation of a humpback and a predictable pattern of degeneration. So let's look at this person who came to see me for tingling and numbness in the hand, and I noticed that he had a large radioscaphoid swelling dorsally. So I teach my residents that if you see a radioscaphoid swelling which is eccentric to the radial side of the mid-axis, unless proven otherwise, it's either a snack or a slack because it's a predictable swelling. Sure enough, we got his x-rays and that's what it showed. And this is the range of motion. This is 40 years since he sustained an injury in high school. And he had absolutely no interest in any of my advice for that. He came to see me for carpal tunnel syndrome, thereby just reiterating the point we made that all scaphoid non-unions do not need addressing in the future based on whether they're B1s or B2s. Here's someone else with a slack, again sustained as a football player in high school, and he is 69, and he came to see me for something else, and he had this radiodorsal swelling, so I got an x-ray, and sure enough, he had a very advanced slack wrist, again proving the point that you have to treat the patient and not the x-ray. So what have we learned so far? We learned that all scaphoid non-unions do not necessarily go on to have a snack. In a slack, it is vital that you get x-rays of the other side. Now, some published data not too long ago showed that there's a small subset of human beings who are born with an inherently increased distance between the scaphoid and the lunate. That is just the way they are. So one of the things I like to teach my trainees is that unless proven otherwise, do not assume that every scapholunate distance increase is pathologic. Get an x-ray of the other side. And if you're going to measure carpal angles, you got to place the x-ray machine in a way that you measure a 0 rotation PA and a 0 rotation lateral. Otherwise, they are not very significant. All SNAC and SLAC don't give you symptoms, as we just saw, and all symptoms do not need an operation. So what are the choices in treatment? You can either go the non-operative route, or if you go operative, you go bony or non-bony. If you go non-bony, it's denervation. And if it's bony, you decide whether it's motion sparing or sacrificing. And if it's sacrificing, it usually means there is fusion. So what are the motion sparing choices? You have the styloidectomy with or without neurectomy of the AIN and PIN, scaphoid excision 4-corner or 4-bone fusion, and a PRC. And the new kids on the block, where you do lesser or limited amounts of fusions with either a 2-bone or a 3-bone. The non-operative treatment is largely reserved for the elderly or the moribund who are unsuitable or unwilling for surgery, and it really is irrespective of the SNAC and SLAC stage. So my choices for a SLAC 1, besides the non-operative ones, is styloidectomy, either open or arthroscopically. I prefer the open. Now, Siegel and Gelberman, in a very good study on cadavers in '91, showed that the safest amount of styloid that you can excise usually should be no more than 4 to 5 millimeters, so that you don't damage, as Greg alluded to, the radioscaphocapitate ligament, which is very, very critical to avoid ulnar translocation of the remainder of the corpus. Does it work? It seems to work. In 50 to 80%, there is pain alleviation. It's not pain ablation. The big difference, pain alleviation, and you need to make the patient know that. And it's best done for SLACs where they have a reasonable range of motion. But you also have to let your patient know that these results are not durable infinitely and that they will degrade with time, requiring a secondary procedure. And it's best done with other operations. For SNAC 1, non-operative only if patients are unwilling or unable. And usually, if it needs something doing surgically, it's very simple. It's open reduction internal fixation with bone grafting. And if you need a radial styloidectomy, we follow the same anatomical guidelines that I mentioned before. Now again, this is something, it's fairly garden variety treatment for a garden variety situation. SNAC 1 in this young male painter, and it was fixed many years ago with these headed screws, and it gives you a very predictable outcome. But what if you fail in addressing this, or if your non-union has been present for more than 10 years? You have choices of distal pole excision. Recommendations suggested that perhaps not when you have existing capitolunate arthrosis, and even if you do it, you have to expect progressive carpal malalignment over time. More contemporary data suggests that these are durable at least until 15 years. So here's this young lady. She's unemployed, she's in pain, and she has a substance abuse disorder. One of our trainees, unbeknownst to any of us, saw this person, diagnosed this to be a fresh fracture, and unfortunately took them to the operating room and fixed it. Decided intraoperatively that the fixation was inadequate, so harvested distal radius bone graft and put it in there. Now you can see the screw trajectory is no good, alignment's no good. Not surprisingly, by about 4 months, this was happening. And it fell into my lap at about 18 months when there's completely discombobulated. And you can see the screw has a large halo. And when I opened it, you can see that there's literally no scaphoid remaining. More importantly, she was in the throes of a very strong tobacco addiction and a substance abuse addiction. So there was no way that she would be a good candidate for any large reconstruction. So we did a distal pole excision in someone like her, which I felt was the safest and the quickest recovery. And here she was at 2 years. She gotten her life back together, and she had found employment. She had knocked off a substance abuse habit. And it looks pretty reasonable, but you can see there is some capitolunate arthrosis already, and there seems to be a dorsal tilt. Not surprisingly, at 6 years, you can see that the lunate's already tilting and that carpal malalignment is happening. Interestingly, the range of motion is durable at 6 years, and she has no pain, after which I lost her to follow up. What about SNAC and SLAC 2 and 3? Where the choices are PRC with or without capsule interposition, scaphoid excision 4-bone fusion, and like I said, the limited carpal fusions with 2 and 3 bones. What do? I consent the patient for both, or rather, I used to consent the patient for both. I'm going to talk to you more about my bias in a second. And then I decide what to do based on the status of the cartilage on the head of the capitate and the lunate fossa. The age and the occupation used to make a difference to me. They don't anymore. The smoking history used to make a difference to me. They don't do anymore, and you'll be asking yourself why. And the compliance with casting duration used to make a difference to me, does not make any difference anymore. Why? All will be revealed. So this is my procedure. I use full thickness, full flaps. This was taught to me by Bill Kleinman. It allows me to elevate all the cutaneous nerves in the flaps straight off the extensor retinaculum. I don't make a longitudinal arthrotomy. Every time I do one of these, I make a capsulotomy as shown here. The blue dot shows the radial Lister's tubercle, and that's my capsulotomy, which goes all the way to the styloid and all the way to the DRUJ. And it goes to the base of the third metacarpal. Once you elevate it, you look at the surface of the capitate, and you look at the lunate fossa. Here's the flipped over capsular flap, and then you maintain your radioscaphocapitate ligament. To get the distal pole of the scaphoid, I find that the Kereson's rongeurs used by our spine surgeon friends are very useful. Once you've seen the head of the capitate, you decide that it's okay reasonably. I put 3 sutures here with a Tevdek. You don't tie the sutures until you've placed all of them. Otherwise, placing the second and the third one is very challenging. You place all 3 of them, and then you tie them in succession, and your capsule just sits in like a beautiful little trampoline for your capitate to sit on. So here's a 38-year-old manual worker with a stage 3. He smokes a pack of cigarettes a day. There's no way I'm doing an osteosynthesis on him. So he was a good candidate for a PRC, and here he's at 18 months with a reasonable outcome, after which I lost him. Here's someone else, a martial arts instructor, didn't want to think about anything that required more than a few weeks of immobilization. So he underwent a PRC, and at 6.5 years, clearly the PRC is not doing great radiographically, but clinically he's happy and he's able to keep his independent business running. Now this is something that I inherited. This person, when I saw her, she was 24 and she was already 6 years out from a PRC done by a surgeon at a different facility. I would not recommend that form of treatment. But here she is, 19 years out from the same operation, and is it looking great radiographically? Absolutely not. But she's got a 60-degree arc of motion and completely unwilling to consider any more treatment. So clearly it's a durable procedure, and we know from Peter Stern's data that durability has been established at about 17 years. But the question is what happens in the longer term, we don't seem to know. And more importantly, how many patients actually get converted to a wrist arthrodesis also remains reasonably unclear until and unless you go to meta-analysis, which we'll go to in just a second. So the pearls of my PRC, I make a capsulotomy for interposition, keep the RSC intact. A styloidectomy should be small. Capitate cartilage must ideally be healthy, and you interpose capsule if necessary. How about someone like this? He's a young manual laborer with a snack too, and for him, I did this. But the key is you got to get your lunate collinear. It has to be completely taken out of extension, and it has to be collinear with the capitate to maintain your carpal height. And it goes on to fuse predictably. Now, we talked about this, but bony prep is the key. As one of my teachers reminded me, and so does my wife, that unless you finish the sanding, you can't put the paint on. So unless you do the bony prep, you can't put your hardware in. And the data clearly does not show any superiority of fancy plates and screws to the simple old humble K-wire. So these are the new kids on the block, which I don't really advocate because, like I said, I'm heuristic and I'm biased, and I don't use this anymore. What does the outcome tell us? Well, the PRC is certainly faster and cheaper. Outcomes are largely comparable. Well, maybe not. Range of motion is better with the PRC and flexion extension, but ulnar and radial deviation slightly better with the forebone. Bottom line is the range of motion is largely similar in both, about 75% of the other side. The grip strength may be slightly better in the forebone, but here's the kicker. Complication rates are much higher, and non-union rates are also obviously present. What does it boil down to? It boils down to surgeon preference. That's where exactly I say human beings are biased and heuristic animals. They learn something and they stick with it because they form opinions. So it appears that we've been taught PRCs are better for people over the age of 35. Maybe not. Maybe it's okay for younger people also. We've also been taught that the capitate cartilage, if it's no good, then don't do a PRC, do a forebone. Maybe not. Maybe consider capsular interposition. No matter what, total wrist arthrodesis conversion is much higher in forebone. Am I saying that just because I've reviewed the data? Well, don't take my word for it. Yesterday I emphasized to you the pyramid of evidence-based medicine. And at the top of the pyramid of the evidence-based medicine was the systemic review or the meta-analysis. Here's something, a meta-analysis. 61 studies, over 3,000 risks, 54% PRC, 46% four corner. PRC much better, grip strength not significantly different, conversion rates much higher for forebone, non-union rates are also higher, and 2.2% hardware removal. Is this my opinion? No. 2024, printed just a few months ago. That's where I'm going to stop. And in case you're wondering why I emphasize the bias and the eurism, I don't do forebone fusions anymore.
So, thank you, Chaitanya. That was an excellent review of all the options and a clear message that don't treat the X-rays, treat your patient. That's very important. So, any questions from the house? Yeah, Bharat.
Thank you, Chaitanya Mudgal. Any difference in outcomes with arthroscopic assisted partial wrist fusions?
So I'm not an arthroscopist, and I know I sound like a Luddite when I say that. I do things the old-fashioned way. I do them open, and I'm happy with them. So based on my review of the literature, it did not seem that arthroscopic procedures gave you any level of superiority in outcomes. But then again, I'm biased.
Thank you.
So, how many in the house are doing arthroscopic fusion? So, do you immobilize after that? So, I think if you are immobilizing, the minimal or open surgery would not make much difference except the cosmetic part. What do you say?
So, you know, each of us has a brain which works a certain way. My brain works with seeing things much bigger. So for me, three-dimensionally, I understand the problem in front of me when I see it in a much bigger field. That's the reason I do it open. And you're right that if you do it open or if you do it arthroscopically, if you're going to fuse, you cannot rely only on your hardware until there's some bony consolidation. So yes, I agree.
Yeah. Any more questions?
Say that again.
Distal pole excision of scaphoid. What is the criteria?
So when you excise the distal pole of the scaphoid, you're excising through the non-union site. So usually you're doing it in patients who have situations where they've been operated. The scaphoid itself is non-reconstitutable, and they are not good candidates for any surgery which involves getting union. So like the patient I showed you there, substance abuse, heavy smokers, diabetics, poor vascularity, I would not do a reconstitutional procedure for them. For those, I would use a distal pole excision. I tell the patient that they should expect an arc of motion of about 60 to 80 degrees. I also tell them that the procedure is durable in published literature up to 15 years. I tell them that they should expect about a 30 to 50% chance of a subsequent operation, including fusion.
Thank you. Still that's time.
Last question, sir. Sir, any PRC has failed? Your PRC has failed, and anything what we can do to avoid that failure?
So if you look at PRC failures, you have to distinguish those which are acute and which are resultant. I don't call them failures. PRC changes that happen to the corpus are a sequela of the PRC. What is a failure? A failure is an inability to keep your capitate captured. And that usually occurs if your radioscaphocapitate ligament is injured. You get ulnar translocation. In my opinion, that's the kiss of death. If you get that, all you have is wrist arthrodesis. Now, going back to your question about PRC deteriorating with time. Yes, they do deteriorate. We know from Peterson's data they deteriorate. Average durability is about 17 years. If they deteriorate radiographically, doesn't mean they deteriorate clinically. But if they do clinically and radiographically, then yes, only thing you have left is an arthrodesis.
Thank you. So thank you,
Good morning.
Chaitanya. I think we are finished the time. You can discuss it later on with them. So we go to the next class. So our own Dr. Sudhir Warrior from Mumbai.
Can I have all the lights off, please? All the lights off? Yeah, I just would like all of you to shut your eyes and put yourself in my place. And I'm going to take you through a story. My screen is going to remain blank, so please do not worry. Please shut your eyes and think about this. I've operated this middle-aged, very important lady, very well-known lady, and I'm doing her first dressing on the 4th day. Her arm is outstretched. I've opened the dressings. She doesn't want to look at her wound, and she tells me, "Doctor, how many stitches are there?" And I quickly make a count, and I tell her, there are 8 stitches. And she said, "Oh, but doctor, you told me there's going to be only 3 stitches. My knees turn to jelly. I have dust in my spine. I have no way of escaping what I had already done." Now you can open your eyes. I had made a wrong side surgery. I had done my first wrong side surgery, sorry. I was meant to do a decurveyance release. In my bluster, in my youth, when I was so happy, I started getting busy. I failed to do certain things, and I ended up doing a carpal tunnel release in that moment. I looked up literature, and this paper came to make me feel just that little bit better, not really, but it said that in a career spanning 35 years, 25% of surgeons in the US will suffer from an event of wrong side surgery despite all the care. And unfortunately, this paper goes on to say that only 50% surgeons report such events, which means 1 in 2 in this hall can easily become a victim of what I was a victim of. Have you been through one yet? If not, please take care now and forever. Can I have the lights on, please? So I'm going to try and speak about some of the errors in my career. As a young resident, I was operating my first distal radius fracture in a public hospital. My registrar was exam going. He didn't have the time to wash in. So he suddenly just stood over me and said, come on, come on. It was in the evening, and he wanted to get back to the library. And he said, cut, cut, cut. And I cut the radial artery. I was young and I was eager. I refused to think. I did not pay attention to anatomy. I was doing my first radial club hand as a consultant. It was a very small child with a very bad deformity, and I cut the median nerve, and suddenly all the fascicles were staring me in the face, and I realized I'd made the mistake. I was so young, I was oblivious of the different anatomy that I was going to face. Me and a colleague sitting in this hall, we had a horrible tourniquet mishap, and we left the tourniquet on for far too long. And suddenly when we released it, the heart began going haywire, and we had a lot of problems which eventually settled down. I was young and I was very smart. Well, errors committed during our youth don't seem to belong to us. They seem to belong to the circumstances that pushed you there. It always feels that I wasn't at fault. And then you grow up, you become responsible, you become aware, and now errors begin to frighten you. Sometimes it may be just a simple error that you trusted a report. So be careful about reports. This report says, and this is from Dr. Anil Bhatia, this report says severe right radial nerve involvement. What luck we didn't operate this one. Here's a patient with a very obvious problem on both sides. Terry Thomas seems to be smiling at all of us. And yet it says no significant abnormality seen. So please don't rely on reports, because there can be big errors. Says no cervical rib. Brings me to this patient, who is a patient with pain in the subungual area over 3 years, has had an MRI, no relief, and we're looking for a glomus tumor, reported as no glomus tumor. That's the MRI, doesn't show anything great, wasn't done with the contrast, and it said no glomus tumor detected. When we looked up the pilot films, which they don't normally put on MRIs, they sometimes send it with the CT scans, but on the MRIs they don't send you the pilot films where they've taken the cuts, so you can correlate your position of pain and look at the MRI and decide whether they've given you a good report or not. Well, there was this, we asked for the pilot film, and it showed that the slices were 4 millimeters, and if there was a tumor of that size there, it would obviously escape detection. So how easy is it to convince a patient for another MRI? They normally think that you're trying to earn money by wrongful means. But we did manage to get this patient to get an MRI. We did manage to find the tumor. And what was happening was that it was hiding, the lesion was hiding within the slices. So you need to be very careful when you're looking at these reports, or else you could have a problem. Here's a young man who had a glass injury in college and came with inability to flex his thumb. There was a little irritation of his median nerve. I went ahead and repaired him, and he did extremely well. Then why is he in this lecture? Because a year later, he developed progressive irritation, he developed pain, and he developed ulnar nerve symptoms. And I got an X-ray then, which I should have got a year ago. So don't rush in before you covered all your bases. It was a glass injury, it needed an X-ray to be done. I forgot to do it, and I had a price to pay. So that was the small wound which missed my attention at that time. Tendon surgeries, lots of problems. So you need to be very careful, obviously, and we have sessions after sessions here and in the adjoining halls, in the rehab halls, where they talk a lot about tendon surgery. Now here's a 2-month-old injury in zone 2 in a seafarer. And this is when I opened him up and I said, oh, let's see whether these ends still come together, and they did. So I did what I, in my mind, called a delayed primary repair. At 4 weeks, he was looking like he's doing fairly well. And 6 months later, he came to me and said, you know what, I'm not feeling too good. This isn't moving too well. Can you do something for me now? So we did a tenolysis, and he was looking very good then. He went home and he ruptured. Within a month of the tenolysis, he was driving, and suddenly he called me up and he said, Doc, I don't know what went wrong. I heard a snap, and here's my finger, it's straight again. So now we did a 2-stage reconstruction. And he went off on one of his voyages. 8 months later, he turned up, nice supple fingers, ready for a graft. checked the graft that it's going to work well. And 3 months later, he embarked on another voyage, disappeared, and then sent me these pictures saying, I'm still not all right. So right from all these stages, he comes exactly back to where he was. And the lessons that I learned are that if it's tight, it's not right. When it's a delayed union, be careful, check the cascade, see that you have, you should have done grafting probably at the first stage. The second thing was that this fellow was a seafarer. Trying to catch these guys, get them through rehab is always a big, big task. And once they get back, the kind of work they do, they're going to harm themselves somewhere or the other unless they've healed completely and they've got the power enough to go back to do that, to do their jobs. Adherence to rehab protocols are very difficult in people from outside states, from states away from where you work, and also in patients who are impatient as well as people who require to do very, very heavy work. Coming on to distal radius, here's a patient whom last year, I think, I thought I had done a very good job getting in a plate. And as Greg Bain showed earlier in the morning, I failed to capture that, which jumped over the ulnar corner, jumped over the plate, and I had to then go in and put it back. And I temporarily pinned it down and held it till it healed. Here's a patient who many, many years ago, and you can see from the quality of the slide that this is a very, very old image, came to me and I looked at this and I said, well, I should fix this. So that was the equation then, and I fixed it with everything I had. I threw everything at it, including the kitchen sink. I had a fixator, I had wires, I had circlage wires, and it still would, and I already broke off a small piece, and it still wouldn't look very stable. So my equation became a little more difficult now, and that's what happened. It slid down. So I said, okay, now let's see what I can do. The equation is difficult. I put a fixator trying to get it back into length. Well, in those days, we thought fixators could cure everything, including all the distal radiuses that we did ligamentotaxis on. And then the equation started getting a little worse, and I got a little worried, so I took out some iliac bone graft and I put it in, and I just put one wire right through, and I said, let it just unite, and then I'll get it to move. My equation was looking a little murky by now. And that's how it healed. And that was the finger, and I told him, go and get some physiotherapy. And that's when I learned that the patient's sister is a physiotherapist. I think I hung myself on that one. Here's a patient who came to me with a garden variety of the volar lip fracture with a dorsal subluxation, and I did a close reduction. There's a large chunk of bone with the middle phalanx, and it came back into position. I gave him an extension block splint, and I sent him home to another state. He is a national level cricketer and quite a famous guy. So he went back to his town, and I told him, you need to keep this on for so long, and then you need to do this, and then you need to do this. So we gave him a protocol, and he went back. His physiotherapist looks at the position of his finger and says, and this guy is a finger spinner, and he says, you know what, you're going to be stuck in flexion, you're going to have a flexion deformity, so you need to extend. So he extended him, and this is when I sent him away. And then he came back to me with a redislocation, obviously, with a resubluxation. So I reduced him a second time. In fact, there was a conference there. I reduced him a second time, and I did exactly the same, put him back in, and I came away. And the physiotherapist comes along again and convinces him that I was wrong. So he managed to convince him that he should get, he should go into extension. So he comes back to me very stiff. At that time, I didn't do the hemi-hamate myself, so I called Binu and I told Binu Thomas, you've done a few, can I send this guy over to you? The patient refused to go to CMC and instead chose to go abroad and got a joint replacement done. That ended his career. So I don't think every solution available is good for us. We need to understand the solutions that match our needs, and the normative data study is going to help create those solutions for us. And I think that's a very, very big step that the ISSH has taken. So I should have been more assertive. The error that I made there was I should have been more assertive. So this is a boxer who had a fracture and he kept on boxing, and I decided to fuse him in the functional position. But then he said, no, my boxing glove needs my thumb to be in a different angle. If I don't box, I can't do anything else. So I get the gloves on, I get x-rays, I calculate the angle at which I'm going to fuse him. And on table, so I calculated the angle, these lines have moved in this x-ray. So just on the day of surgery, he mentions that competition gloves are different from training gloves. So I sent his assistant back to the hotel, got the competition gloves, on table calculated his angles, and got him fused. He went on to do well. And this is the last case that I'm going to talk about, and that is age and experience are no bar for making errors. This is not day before yesterday, this was day before yesterday of the last time I presented it. Now here's a patient whom we had fixed the radius and the ulna, and comes the time for implant removal. I schedule this patient, and I go and check up my records. So I work in 4 or 5 private hospitals. So I keep my own records. Each year I have these little diaries where I write everything. I make little notes and I put them in so that I know exactly what I'm dealing with. And here's the note for this patient. It said fracture lower end radius and ulna. Radius, the name of the company, Sorat plate, locking with the golden rings. So what details were there were almost good enough for me to know what I had put in, because we use different companies at different hospitals. And the ulna, there's a ditto mark for the company name, and it says 2 mm. So I was fairly confident of what I was going to do. And I opened the radius. I checked my records. I do have photographic records, so I go back and see the plate. Just a couple of minutes. I go and see the plates that I had actually put in. So I see the visual image of those so that I know that I've used this plate. It matches my records, so I'm not going to make a mistake. So I do that, I've checked this, and I find there's no picture of the ulnar plate on that day. For some reason, I did not take it, so I didn't have those plates. So we were operating in a different hospital, and as soon as I open up, I have a heart attack. It's a different company, and it has a triangular screw head slot. Which company has triangular screw heads? Well, there is one. There's no screwdriver, obviously, never. It's the Hindu New Year day. Everything is shut. Uma Surgicals is closed, and they're doing a puja. The dealers are closed. There's just no way you're going to get anything. So I asked for my non-surgical set from home. It's going to come through a courier. It's going to take 45 minutes. Sterility remains a problem. I hope I'll be able to find a solution in this thing. This I used to carry to all the cases. And I stay 16 kilometers away from the hospital. But fortunately, Dr. Nikita Shetty was with me, and she has a set of instruments that for the broken screw retrieval set. And we had never looked through all the screwdrivers to know what was in that set. And fortunately, on that day, there was this triangular screwdriver in that set. And
Dr. Warrior,
yes,
can you close? We will have some questions.
I'm done. So how could I have prevented this? I could have prevented this. All the problems lined up. And therefore, we felt, despite having so many checks and balances, we went right through that. And lastly, there are some errors that you'll never regret. These are all my colleagues from my medical college. The error I made was I was very slow, and I remained like this at the end of my medical college. But that was one error I'm never ever going to regret. So learn from your mistakes. Nate. Thank you.
So, questions? I think this is a very important lecture. Very few people report their errors, as he mentioned. But the society doesn't tolerate errors at all. We all know this. So now it is not 25%. He quoted the literature from 2005.
it is much less the wrong side. I think we should all be aware, we should mark the site, we should doubly ensure before the surgery. And of course, when we listen to such lectures, every time we operate, we should remember that I am not going to cut the median nerve or the radial artery. Then we will be able to save it.
Thank you very much.
Okay, thank you.
You know, I just wanted to make a comment about Sudhir's talk. Sudhir, tip of the hat to you for having the gumption to come up with this. We live in as surgeons, we live in an environment and in a culture where making errors is looked upon as something that's not right. Guess what? It's part of who we are. It just takes a special person to stand up and say, hey, you know what, I goofed. But we have to change our culture. That machismo has to go away. Our culture has to be one of understanding, forgiving, and moving on, and not a culture of shame. So thank you for bringing this to our attention.
Hello. So we have a oration planned at 10 a.m. So once the oration starts, nobody will be allowed to go out of the hall. So if you want to take a break, please take a break now, and we'll assemble for the oration at 10 a.m.